Jennifer Sheeta Brom.
He got my name. Now you give him a round of applause. No one gets my name, so good job.
So Jennifer is a licensed clinical social worker who's been practicing at Southwestern Behavioral Health Care for the past 19 years. She specializes in older adult population and is the state and federal pre-admission screening resident review programs. She also is an adjunct instructor teacher up to 3 times.
Three classes.
Up to 3 classes at a time at the University of Southern Indiana for the social work department, in addition to working full-time for Southwestern. She is a team leader for the Red Cross Mental Health Disaster Team and a co-leader for the Indiana State District 10 Disaster Mental Health Response Team. So thank you very much. Let's give her a warm welcome.
Thank you.
Should be on time. Hello?
You're good?
Yes.
Yeah, give him a round. I see a lot of Smirka friends in here, so that's good. Okay, well, I'm Jenny. You don't have to pronounce my last name, so just call me Jenny. I want it to be very informal, so if you have questions throughout, that's fine. We don't have to wait till the end. Or if you have case examples or things that you want to discuss, I think that's beneficial to everybody, so please feel free to raise your hands throughout. That's fine. I have handouts that if we don't get to everything, you can review on your own, because, of course, 3 diagnoses: dementia, delirium, depression, we're trying to cover today, and you can have whole day sessions on each one of those. So, and I know some of you are professionals already, some of you are probably nurses, social workers, etc., and have a lot of experience already with dementia, delirium, and depression. And some of you may not have any experience. Maybe you just know of a loved one that has had dementia, or you've had experiences with depression, etc. So it's hard to tailor a presentation to all levels in 1 hour. So I have lots of handouts. Now, yes, the first day that email was sent out for the handouts online, there was only 1 in there. So if you already printed that, you need to go back. There's 3 in there now. You'll have my PowerPoint now, which wasn't in there the first day. Okay? My PowerPoint is in there now. And I made a copy of the 3Ds, which she just handed out. The comparison list, that is also online too. Okay? But I went ahead and made a copy because I didn't see it the first day. But we're going to go over that today too. And when I pulled it up online, it was little print, so you have a copy with you. And this was on there the first day, the virtual mentor. It's a clinical pearl, and it's written by an MD, and it's talking about differentiating among depression, delirium, and dementia in elder patients. It's very good. It's an easy read, it's not over your head, and it really brings together the main points that I want to discuss today. So if I talk too fast, which I tend to do when I'm trying to hurry and get a lot of information in, you can always raise your hand and go like this to me if I'm talking too fast. I won't be offended. So, or, I tend to do that. So, Linda, you can just say, she's a good friend. Dixie too. Carolyn, just go, slow down. That's fine. Anyone can in the room. So, tell me to slow down. Okay? But this will do a really good job of bringing everything together, the main points that I want to get to you today. So please read this. It is an easy read, and it does bring everything together nicely. Also, the 3D chart, the 3Ds right here, it breaks the main points down for you very nicely too, to try to differentially diagnose what's going on. The main differences that you're going to need to look for in the 3Ds. Okay, when they're superimposed on each other. So, when you're trying to tease those diagnoses out from each other, this chart will really help you a lot. I also they handed out the quiz, the 3D quiz, and hopefully we'll get time to do that together, but if not, you can do it on your own. I do have the answers up here. I didn't want to hand them out yet, but make sure and do not leave the room. If we don't get time to do it together, make sure and pick up a copy of the answers, okay? But when we take this, it'll do a really good job of helping us to sort out to the main points of this presentation and helping us to pick out the main points I want to get across to you, okay? It talks about definition, the duration, and the other symptoms of the 3Ds, the depression, delirium, and dementia. Okay? All right. I want to ask, I kind of get a feel for how much you guys know already. Can you tell me, just raise your hand, if you think dementia is a normal part of aging? Wow, you guys are good. Dementia is not a normal part of aging. Absolutely not a normal part of aging. It is more common as we age. It gets more common, especially in the later years, as we've already heard today. So you've already got educated a lot. It's been a very good conference already, right? We've really been educated. Let me ask you, is depression a normal part of aging? How many, raise your hands if you think depression's just a normal part of aging process. Awesome, good job. Maybe just like, well, I'm not going to raise my hand on any of these. Depression is not a normal part of aging. Depression, it increases the likelihood of you getting depression will increase as you age because we do go through a lot of losses and we have a lot of medical changes and problems as we age. The medications we take and things, some side effects can cause more depression, especially like if you suffer a CVA, which is cardiovascular accident, a stroke, especially for some reason a left-sided stroke, that can increase your likelihood of getting depressions. Also, the coronary artery bypass grafting, those goes way up your risk of getting depression. Actually, my grandfather had coronary artery bypass graft, and he recovered fine from that, but he got major depression after, and he never recovered. And he died from major depression. We could never get that controlled. And so that's what really he died from. So oftentimes that's where it's been diagnosed, is that cardiologist's office. This is the major depression's being diagnosed there. So that's very common. And so when I'm doing my assessments, that's a lot of times what I'll look for. Have they had cardiac problems, and have they had surgery, open heart surgery especially. So that's one of the main things I'm looking for to try to tease that out. So depression, definitely not a normal part of aging. Dementia is definitely not a normal part of aging. What about delirium? Is that normal? Anytime to get a delirium? No, of course not. Do you think it's more common in older adults? Definitely. Post-surgery, 50% higher in older adults, post-surgery, to develop a dementia after. A delirium after. Especially the anesthesia, they don't clear it as quickly. The medications like narcotics that they're often given, or benzodiazepines, which are like your Ativan, Xanax, and things like that to calm them down after surgery or before surgery. Then you have the anesthetic on top of that. They're mixing and things. Then you have your narcotics for the pain medications or the pain pump, morphine, etc., all mixed in with all that. Then your kidney function's not working as well, so they're not clearing that. Liver function's not as well. They're not clearing all that toxic stuff out of their system as quickly. Maybe they're in the ICU. Have you heard of ICU psychosis? Okay. That happens a lot where they're, the lighting, they don't know times of day, they get that mixed up. They're not prompted to the time, the orientation's off, and you have medications, of course. You have the call lights and the sounds, and they're getting very confused and disoriented, afraid, paranoid maybe, those kind of things. So you have all those in combination, and they have a delirium. And they might have a dementia too. So they have a dementia, they're going in maybe mild dementia. Then they have the surgery, they come out of surgery, they have all that going on, then they have delirium superimposed on top of dementia already. So now you have two things going on. So then they went to go into rehab at maybe a nursing facility for short term. So they had a little bit of dementia, they have the delirium, maybe it's not all the way cleared. They go into a nursing facility for short-term rehab, then they become what?
Depressed.
Yeah. So now they have depression on top of it. Then they're not healing as fast. Then what happens? They don't want to get out and do what? Therapy. Right. Or they're not motivated. And then what do they call them? They're what? Not compliant. Right. And a lot of times what happens, they don't get treated because the depression is not diagnosed, right? Depression doesn't get diagnosed. Although depression, I can't remember the statistics exactly. Is it 60% of nursing home residents have depression, clinical depression, that's not diagnosed? I believe it's 60%. I can't remember exact statistic, but high numbers that are not diagnosed and treated properly. So now we have all three. And sometimes the delirium doesn't clear right away, or they're adding more medications on because they have the agitation. So then what gets added? Antipsychotic, right? So now we have more things, or more increased benzos. Let's increase that Ativan that was started at the hospital at 0.25. You know, we had a little bit at night. Now we're going to increase it to 3 times a day because they're agitated, right? And then we're going to add some of the Seroquel on at night. Yeah.
With the depression diagnosis needing 2 weeks before it can be diagnosed.
It's clinical depression, right.
Clinical depression.
Mm-hmm.
How does that affect the ability to treat that if you start seeing signs of depression early on in a rehab stay?
Okay. She's talking about the 2-week criteria for a major depressive disorder. We call it clinical depression. We look at, there's a difference between depressions, right? We have adjustment disorder kind of things where maybe you lost a spouse, or you're going into the facility for rehab, you're depressed because you broke your hip, or you're having to go for rehab, you're away from home, you're away from your dogs, your animals, you're lonely, that kind of thing. But you're just having some mild symptoms. You're just irritable, you're just, not as joyful, you're having some feelings of hopelessness, but it's not severe. You're still going out, you're still doing therapy, you're still eating, you're kind of down, okay? That's more adjustment disorder kind of things. You're not meeting clinical depression. It's not staying around for 2 weeks or more at a time, and it's not meeting 5 or more criteria of the severity, okay? You only have a couple of the criteria met in what we call the Diagnostic Statistical Manual for mental illness, okay? So you only have 2 or 3 of those. But if it's 2 weeks or more and you're meeting 5 or more of the criteria, then we're looking at clinical depression, okay? That is when we diagnose clinical depression, and you need to get that treated. And oftentimes we come in, like at the mental health center, and do an assessment. Hopefully nursing's looking for that if you're in a facility, and hopefully that's why I'm here to teach like family members. Wait a minute, something's really wrong. They're totally different. They're very withdrawn. They're meeting some of those symptoms I have down there. And it's been 2 weeks or more, and they're totally different in their level of functioning. That's really what you're wanting to look at. So we need to talk to our doctor.
What do you do during that 2 weeks when you see it coming?
When you see it coming, well, you need to watch them. I mean, if you're seeing it right away, we need to look at the time frame though, because you do need to give people some time to grieve and time to work through things, especially if they've had a loss. Give them some time to grieve. I don't want you to start medications right away. Sometimes people jump the gun on that. I've even had doctors start people on preventative. Like they'll say, oh, their spouse is going to die. We know that they're in hospice care or something. Well, we'll go ahead and start an antidepressant on them. They haven't even given them time to grieve or start an anti-anxiety medication because they think they're going to get more anxious. You don't want to do that. You want to let them go through that process of grief, and you want to have them deal with things and cope with things and not do it with medication. And oftentimes you want to just try psychotherapy first. Yeah, we want to always try with like talk therapy, the least invasive things that we can do first before we go to more invasive things like chemotherapy, such as antidepressants and things like that. So we definitely want to do that first, and we want to make sure that's why they have the 2-week criteria on there and the severity levels, and you have to meet that many criteria. That's why they have those criteria in there. But we do want to keep an eye on them. Now, if they ever say they're going to kill themselves, you need to ask the question. Suicidality in elders is very significant, especially in older Caucasian males. The completed suicide rate in that population, 80 plus, is the highest rate of completed suicides. So that question needs to be asked, especially if if they've had a history of suicide attempts, that will increase the risk. If they've had another family member in the past commit suicide, and if they have a firearm in the home. You always have to ask about firearms. That's another huge risk if there's a firearm in the home. You need to ask that in an assessment. So those are big risk factors. So you need to be asking that question. Have any of you heard of QPR? Question, persuade, refer. It's like CPR, but it's QPR for suicidal people. It's an acute intervention. We offer it at Southwestern a couple times a year. You can get on our website. Deaconess Crosspoint offers it, I believe free to the community as well. And I think it's a couple hour night training session that we offer it free to the community. So it's like a CPR training, but you're doing it QPR training to intervene with acutely suicidal people. So I highly recommend that you try to do one of those sessions. Okay? It's called QPR, question, persuade, refer. Okay? So just punch that in Google and you can find somewhere to get a training. They usually have links to your local areas. Probably Southwestern will be on there and Deaconess Crosspoint will be on there. I don't know if some of the other Brentwood Meadows might offer it too, or some of your other local areas. Wherever you're at, Southwestern or Southern Hills and Jasper, for example, might have a training too. Most mental health centers will have a training for question, persuade, and refer. And we have a separate one for like high schools and things too. We're trying to get people to intervene. Because the suicide rates in this area are very high. Vanderbilt County especially has a very high suicide rate. So, and older adults too. Okay, well, I have this PowerPoint, but I actually like my chart better. And I want to take a little break and do a 9-minute clip. I know I hate taking away time talking, but I think this clip is very beneficial because it's about normal pressure hydrocephalus. Does anybody know what that is? Anybody heard of NPH? Well, good. I'm going to... Yes, it is. I just love her. I'll give you a hug later. Okay. Actually, yes, it's swelling in the brain. It's actually, we're supposed to have 1 ounce of water in our brain. It can be up to 10 ounces when you have normal pressure hydrocephalus. And it can cause significant dementia-like symptoms. They can appear to be very demented when they're not demented at all. And if you get a shunt put in, like where it drains, they could go back to previous level of functioning. And I wanted to point that out because that is very underdiagnosed. It's not diagnosed very much at all. Actually, out of, what was it? My statistics. Out of, there's 7 million people diagnosed with Alzheimer's type of dementia in this country. About 375,000 people could have NPH. I mean, that's pretty significant. That's not diagnosed. And I don't see it diagnosed around here very often at all. And I'm writing that on assessments and things, consider an MRI or CAT scan, because that could be, it's often misdiagnosed as Parkinson's disease because of the shuffled gait. And people can almost see it. And it's often misdiagnosed as Alzheimer's as well. But the reason I picked that, the clip talks also about just the challenges of diagnosing, differential diagnosing, and why people are often not diagnosed appropriately. Because of the time you have to spend. Doctors often only spend a few minutes with patients. They're in and out, especially in a hospital setting. How many minutes do they spend with a patient? Very few minutes. And in nursing facilities, I often have patients tell me, I don't see the doctor. I haven't seen a doctor. And these are alert and oriented patients telling me this. Now, a nurse practitioner may be coming in every other month, but they'll tell me they don't even see the doctor. I've had doctors, I'll be reviewing a chart in the courtyard area, when you're in the middle of the facility, and the doctor will be doing an exam right there. Now, who's going to tell them anything when you're around all these other residents and they're doing the exam right there and ask them how they are? They ask them how they're doing. Okay, let me listen to your lungs, and they're actually listening to their lungs right there. And that's the whole thing, and that's the month they'll see them. That's what happens. Now, how in the world do you really find out what's going on with them? And The hospitalists only see, they don't know their history. They don't know if they were alert and oriented their whole life, and so they diagnose that dementia. That goes on their chart. They've never really had any confusion or disorientation before they went in the hospital, but now they're labeled with dementia because they're sure appearing confused and disoriented when they go in, but they're having an actual delirium going on. And you know, the first thing I said when my grandma went in the hospital, I said, she's not ever had dementia. She was 85, and I said, because she was very confused when she went in, I said, she does not have dementia. She was fully functional before she came in here, because they wanted to write her off as having dementia, and that happens all the time. And then what happens is that gets diagnosed, and it stays on their chart, and they're labeled with that, and they get written off the rest of the time. It's, oh, they're just confused and demented. And that follows them.
So Jenny, what do you do about that?
Well, I always write on my assessment that diagnosis needs to be changed. And I will tell family members, you need to get to medical records and have that changed in that chart. And you need to talk to your physician about that. That needs to be changed in the next H&P that they do.
So what do you do about that process of the way, that pattern of medical
Advocating.
care?
If they have family members, they have POAs, and themselves. I say you need to talk to your physician. You need to talk to your hospitalist when you go in. But if they're confused or disoriented, they're not going to be able to do that. So they need someone in their family that can do that for them. A lot of times I'll talk to family members and they're just completely astounded that they've been diagnosed with the dementia. I've had people diagnosed with schizophrenia because they are confused or psychotic due to delirium, or even dementia. They'll be diagnosed with bipolar. They'll be diagnosed with schizophrenia because they're having a psychotic episode from a dementia or delirium.
So who thinks that's okay for a doctor to spend 2 to 4 minutes with a patient and put on a diagnosis? Why is
Exactly.
it okay?
It's not okay. And that's why I do this job.
Is that standard of care? I mean, is that
That's what
really
happens, though. I get in charts every day, and that a lot of times that'll happen. A lot of times medications are started to treat a dementia, or agitated dementia, like they might have a few behaviors in the hospital because they changed environments, and they're confused and disoriented, and so they're acting out, or they got a new medicine put on and they're more confused, or they're having a delirium from an infection or something, and they're having behaviors, so they get started on a medication, and that medication just stays with them. And they don't get a DC'd, it just stays with them, and they're just on it forever.
So
And
that's a macro system issue.
Yeah, absolutely.
I mean, we really aren't going to be able to address that patient by patient by patient.
Families need to look at charts. We need to educate our patients and clients to look at their charts, look at their medical records, find out what they're taking, why are they taking it. Don't just take something because your doctor says take it. Why are you on the Seroquel? What's it for? I ask people, why are you on that? What are you taking that for? Well, I think I was started on it when I was at the hospital last time, and I just take it because my doctor keeps prescribing it. Well, why are they prescribing it? And then I'll call the doctor's office and says, why are they on that? The nurses have no idea. Well, they were started on it at a hospital that time, and then when they go in the nursing facility for some reason, or rehab or whatever, they have to have a diagnosis for that medication. So they'll say, well, put bipolar on there, or put schizophrenia, or put dementia with behaviors. They're not having any behaviors. They're perfectly alert and oriented and fine now, but they have to have a diagnosis for that medication. And it just infuriates me. And then when I tell people, well, I'm here to see you for a mental health assessment because you're diagnosed with schizophrenia, and they're like, what are you talking about? And I call their family, and they're saying, they worked at Whirlpool for 40 years, and they have never ever once been in a mental health inpatient unit. They've never once had problems with mental illness, but they're taking this antipsychotic, and I have to find out why they're taking that antipsychotic. And they're like, well, why are they taking that? And you know, you're spending all this money on this medication every month, or Medicare is. And it happens all the time. Well, my doctor told me to take it. So we need to be more invested in our loved ones' health care and our own health care, and advocate for people.
I don't know know how many people in this room, and maybe a lot of them are aware of it, but, you know, a urinary tract infection is most
Absolutely, that's a huge one,
check them for
especially in older adults. And I am always telling people to get UAs, the urinary, well, any kind of dementia workup. That's part of a dementia workup, we call it. Anything, we want to rule out anything reversible that's going on with an acute, something acute that is making a change in their mental status. So if you go in the hospital and you're confused, you're disoriented, you're really agitated, you're not sleeping, or you're having a sleep reverse, their sleep-wake cycles reversed, or even young people can get a delirium, definitely. So something's going on. I went in and saw a younger gentleman, and he had not slept in 5 days, and he was very agitated, and they were telling me, you got to get him out of here, you got to get him out of here to the facility, you got to get him out of here. And I'm like, he's so agitated, he's like constantly looking out the door because he was so preoccupied, he was paranoid at that point, he was hallucinating, he had not slept in 5 days, and I'm like, he's not slept. I told the nurses, and that's why he's getting increasingly agitated. You need to address the sleep. He's not slept. So he's got a delirium. You need to get him to sleep. They just wanted him out the door because he was getting more and more of a behavioral problem. He was pulling the sheets off the bed. He was undressing. He was so agitated. And he was delirious. So it's like, that's part of a dementia workup too, or a delirium workup. We want to get the, are the electrolytes okay? Are you dehydrated? All those things will mess with your mental status, will make you confused, can cause even psychosis. So, sleep, yeah, absolutely, sleep deprivation, even. And young people too. Any medications can cause problems too, especially narcotics and older adults, and benzodiazepines too. It can cause memory problems, definitely. Any anacholinesterase inhibitors, those will definitely, like Benadryls and the narcotics and all those kind of drugs. Even blood pressure medications can cause problems too, a lot of the different medications. So you really need to be careful. And then they interact. So, like at our memory care clinic at Southwestern, that's one of the things that Dr. Wood does. Our geriatric psychiatrist, she'll look at all those medications you're taking and make sure that none of that's going on, and that they're not interacting with each other. And also you got to check levels. Like if you're on digoxin or if you're on lithium, if you took that dose when you were younger, that dose may not be appropriate when you're older because you're not clearing things from your system as you did before. Also, substance abuse. You don't think older adults are abusing substances? They are. They're abusing substances, absolutely. And the baby boomers are going to be abusing substances more. So, yeah. So that's something you're going to be needing to assess for. Alcohol, drugs, even more. But they are doing it now. And even our little frail ladies, the Xanax, it may not just be that they misused it, it may be that they're purposely misusing it. So, or taking more than needed, or taking more of their pain meds that were needed. And they may have fall, or they may be drinking too much wine with it at night or something. They do it. So you need to assess for substance use with those medications too. So you have the same dose of medications you were taking at a younger age. Those were never changed by your physician. They take the same dose of lithium they've taken since they were 20. They have bipolar disorder, for example. So they're on that same dose of lithium they were taking since they were 20. They're now 75. Their kidney function is not as good as it used to be. They're drinking the same amount of wine they always did. Then they got a new blood pressure added in there with a little diuretic in it. So now you have all that mixed in, and what's going to happen? What's going to happen? Probably get a delirium in there. They're going to fall, more than likely, break a hip, get in the hospital, go get some anesthetic from the surgery to fix the hip, then they're going to end up in the ICU, then they're going to get ICU psychosis, then they're going to get depressed because they're going to have to go to the facility. Yeah. Right? So you can see differentially diagnosing is extremely important. Okay. Well, let's watch this video, and it'll show you even more how important it is. I gotta get back on. Hopefully it's still here. Yay, it is. full screen?
It did, and then it went back down.
It went back down.
Hit play thing first.
Play first? Okay. I'm not. My students hate me sometimes because I cannot. I usually have a student do this for me. Uh-oh, no volume? Please tell me this is going to
Try
go
on
higher.
the other side.
Now it's on mute.
Yeah, on that, you know, where you make it full screen on the other side.
Oh, over here?
Yeah.
Right here?
Hit small screen again, and then it should pop up down there on the bottom.
Right here?
Down toward the left.
Just below.
Just below
Oh,
that.
I see it.
Right there.
Now, take that out.
Now I'm out of my thing, ain't I? I'll find it, don't worry. I don't hear it though. Hang on. Where is the...
It's probably a tiny one. Oh, it's not, she's not talking to you, you're not going to hear it.
Take this off, maybe? Let me turn this off.
Is it even coming out of this?
Hit play and we'll see. Oh, it's not playing. That might help. Then just move the microphone around the computer and see if it goes loud. That's what I do for a living. No, yeah, just hold it around.
I think there's somewhere you can turn it up.
If Jenny puts her microphone to the speaker on the laptop.
That's what we're trying to do, but it's not even coming out of the...
So they've got it through the wall.
I can kind of hear it.
You can kind of hear it? I wonder if there's some volume on here. Here, I'm gonna let you.
Yeah, that's, it's all the way up.
I might not get to watch it. Darn it, I really wanted to show that too. Well, we can, while you guys are going to get something, we'll wait. And we'll go on, and then hopefully somebody will come. Okay. All right, let's look at this. I'm not going to pull it up on here since you all have a copy of this, so we'll just go over it with, go ahead and pull this out to look at the 3Ds, okay? Here's your definitions. I just want to briefly go over some definitions of, so depression we already talked about a little bit. You're going to have at least 2 weeks. Now that's clinical depression because adjustment disorders are different, like I said. Bereavement's different. Bereavement, of course, your loss. Everyone grieves differently. That's, of course, everyone should be allowed to grieve. Grieve the losses of home, their independence when they go into a facility, or loss of functioning, their level of functioning if they broke a leg. They can cry. It's okay to cry. Don't jump to a conclusion that they're severely depressed because they're crying. It's so often at facilities, for example, we'll get calls that they're depressed and they need to get an antidepressant started right away because they're crying. Let them cry. It's okay. Now, if they're crying every single day, all day long for 2 weeks at a time, and there's other symptoms going on that's causing functional impairment, they're having significant functional impairment in their daily living, their activities of daily living, then you need to look at clinical depression, and that absolutely needs treatment, okay? We can get volume. So if they're having that level of impairment, you need to get that treated. What do you think the success rate is for elders that are treated with psychotherapy and medication treatment? Give me a percentage. Someone said 40. 70? 60? You're getting close. I had her 90, 75. What's in between? 80. Yes. 80% success rate for elders. That's huge. That's why I love working with elders too. I love working outpatient therapy with elders because 80% success rate. That's my best population to work with because they want to do the work and they do improve. Yeah. And sometimes you do have to start medications. Is it working? Oh, okay, that's fine. Sometimes you do have to start the medication because if it's a very severe depression, to even get them to participate in psychotherapy, if it's real severe, you really need to start them on an antidepressant first because they won't even engage with you. I've had someone that depressed. I've even had someone had to have ECT first before they could even engage. So sometimes if it's that severe, you may have to go ahead and start with more invasive. So do the chemotherapy and then start with the talk therapy because it can be that severe. And we also sometimes have to have them see the psychiatrist to look at, maybe medications are causing some of the problems. Thyroid dysfunction, they need to look at that too because that can cause depression. And like I said, the heart disease and other things that are going on, that all needs to be looked at. That could be increasing that depression level. So we would definitely want to do anything reversible or anything that's impacting their mood that could be physiological. Okay, so that needs to be addressed, and then let's do the talk therapy, and then last medications. Okay.
Milt was going to doctors.
There you go. We got it.
Misdiagnosing him. Why
Thank you guys. Thank you. Save the day.
It's hard to make the.
You're the best. Thank you.
You have to sit
Yay.
down, you have to listen.
Okay, let me rewind it.
The patient, and you have to do it in a.
All right, here we go, guys.
For many people, it's the worst possible news. They're diagnosed with Alzheimer's, Parkinson's, dementia, or another debilitating disease, told to put their affairs in order and prepare for years of suffering and eventually death. Millions of Americans have to live with that kind of diagnosis and all the heartache that goes with it. But what if the diagnosis is wrong? What if they're really suffering from something that's treatable? That could be the case for tens of thousands of people, including those you're about to meet. Americans who believe a simple surgery helps save them from senility.
I was totally convinced I was dying. I was totally convinced that I'd be gone in probably a month or so.
Bob Fowler was so sure he was dying that 5 years ago, at the age of 69, he wrote his own obituary.
So, Bob, also known as husband, brother, brother-in-law, dad, Uncle Bob, and the most exalted title of all, Papa, has left us.
Hard to write that.
It was hard to write it.
You thought this was the end and there was nothing that could be done.
I was totally convinced. I was totally convinced because I'd been to doctor after doctor after doctor with absolutely no positive results.
For nearly a decade, Fowler had struggled with debilitating symptoms, trouble with balance, memory, and incontinence. Doctors suspected Parkinson's or Alzheimer's, but weren't sure. His condition worsened so terribly that he ended up in a wheelchair and had to stop working. Eventually, his wife Benita began making plans to put him in a nursing home.
I had to sleep in a chair in the den for the last 3 years of the 90s because I couldn't put my head on a pillow. I felt as if I was suffocating or drowning.
He'd also developed a severe case of dementia. How many doctors do you think he went to?
Probably 15 in 9 years.
In all those years, none of his doctors suggested he have an MRI or a CAT scan, so he never got a definitive diagnosis of what was wrong with him. In Phoenix, retired dentist Milt Newman suffered for 15 years from the same symptoms as Bob Fowler. In Milt Newman's case, a CAT scan was performed, yet none of his doctors could pinpoint what was causing his decline.
My concentration was nil. There wasn't any. Reading a book was difficult because I couldn't remember what happened 10 pages back. And later on, conversation was difficult because I'd forget what people would say.
How old were you when this all started?
Maybe 55.
Which is not old.
Oh, no.
Milt's wife Phyllis says she remembers watching her once vibrant husband simply slip away.
It was like his brain was sinking into his body. That's the only way I could say, you know.
Eventually, you got a diagnosis of Alzheimer's.
That's true. And I was floored by that. Because to that was a death sentence. And I said to myself, well, let me get prepared.
But what Milt Newman wasn't prepared for was the news that it was all a mistake and that there was hope.
Have a seat up here.
Last year, after 15 years of suffering, Milt Newman met Dr. Harold Recate, a neurosurgeon at the Barrow Neurological Institute in Phoenix. He realized that what Newman had wasn't Alzheimer's, but a condition called normal pressure hydrocephalus, or NPH. NPH is caused by excess fluid putting pressure on the brain.
We should have an ounce of water inside our head. This is probably 10 ounces. So there's 10 times so much fluid in here than there is in a normal person.
What is that water on the brain actually doing?
It's pushing the brain outward and stretching the nerve fibers so that they can't function properly.
The result can be the very symptoms that plagued both Milt Newman and Bob Fowler. Problems with gait or walking, with thinking, and with bladder control. To Dr. Recate, those symptoms, especially the shuffling walk seen here in this patient, are a dead giveaway. But doctors rarely realize that the cause might be NPH, and a surprising number of cases go undiagnosed and untreated. So is it almost that Alzheimer's is just sort of the default position? You come in, you're having memory trouble.
You're old, you have Alzheimer's.
And most of the time that diagnosis is correct. Alzheimer's and other forms of dementia afflict more than 7 million people in the United States, but medical professionals estimate that between 5 and 10% of them, at least 375,000 people, might actually have NPH, and most physicians are missing it. Milt was going to doctors, and the doctors were misdiagnosing him. Why do doctors tend to miss the symptoms?
It's hard to make the diagnosis. You have to sit down, and you have to listen, and you have to examine the patient, and you have to do it in a thorough way, and then you have to order an expensive test. An MRI scan will cost somewhere around $2,000 to $3,000.
To think that there are that many people out there misdiagnosed who are just missing out on so much life.
You don't have to go gently into that good night. You need to fight, and we need to give you the tools to fight.
The first tool is knowledge, because once the condition is discovered, the treatment is a 45-minute procedure in which neurosurgeons insert a tube called a shunt into the brain. That tube drains the excess fluid from the brain and moves it to the belly where it can be absorbed. Do you feel the shunt? Are you aware of it?
Not at all.
The shunt may need to be adjusted because removing too much or too little fluid can be dangerous. That adjustment used to require further surgery. Now it's done painlessly with a magnet in the doctor's office. After the surgery, how did you feel?
I came out of it fantastic. I felt like the old Milton.
How soon after?
Right away.
Bob Fowler had a similar transformation in 1999 when finally, after 10 years, he was told he really had NPH. Did you feel like you had gotten your life back?
I never anticipated feeling that good again in my life. And all of a sudden I felt fantastic. I'm 74 years old now, and I'm doing things that I wouldn't have dreamed of doing any time during my 60s.
Has this well started production yet?
Yes.
Today, 5 years after his surgery, Bob Fowler is back at work.
Oh,
And back at play. But he's also a man with a mission to spread the word about NPH.
I'm Bob Fowler, but this was me a couple of years ago.
Here he is in a commercial reenacting what his symptoms were like then and showing how he is now. The ad was produced by one of the shunt manufacturers.
There was talk of Alzheimer's or Parkinson's, but what I really had was a neurological condition known as NPH, normal pressure hydrocephalus. Then I found out that NPH can be treated.
We've had hundreds and hundreds of calls from patients who saw those commercials and said, that sounds like me, it sounds like my mother, my father, someone that I know.
Neurosurgeon Gail Russo is a leader in the field of NPH research. She's working to raise awareness in both doctors and patients about the 3 classic signs of the condition.
Patients and their families should know that if someone is aging and their gait is worsening. Their mental thought processes are becoming less clear, and or they have urinary incontinence. They need a scan. They need to insist on a scan. And they need to see a specialist who knows about normal pressure hydrocephalus.
But even that, she says, might not lead to a dramatic recovery.
We can improve the symptoms of normal pressure hydrocephalus, but we can't make you look younger. We can't slow down the other things that make you feel old that have happened during that same period. Arthritis, perhaps heart disease, the other medical problems that we all seem to accumulate as we get older. This only helps one of them, but when we're right about it, it can help a lot.
No one understands that more than Bob Fowler, who says he feels like he's been given a second chance, and he wants to share it with others. Do you think you see people on the street now, in the mall, at a restaurant?
I can spot them quickly. I've even walked up to people. I have walked up to people and had the audacity to walk up to a person and say, "Have you had an MRI or a CAT scan in the last few years?" And they're, "No, why? What business is it of yours?" And I say, "Because I know your gait, I know your walk. I want you to go from here and have a CAT scan or an MRI. Do yourself a favor."
Okay, you can get the lights. So, now you know about NPH. That's pretty powerful. Do you remember that commercial?
Yes.
I remember it very well.
Helping patients face blood-related cancers with advanced therapies such as stem cell transplants.
Yeah, that commercial really hit me. I remembered it because it's so powerful to get a proper diagnosis, right? So I carry that with me because, and that keeps me digging for the chart, and that keeps me calling when I get answering machines, family, our doctor's offices when they're being a pill, try to get more information, or to deal with people when they're being crappy with me or something, or to really go to bat for somebody, because it's really important to try to find out what's going on. And just because they're old doesn't mean they don't deserve a good quality of life. I don't care if they're 100 years old. You know, they still deserve a good quality of life, even if they're old. I have so many people in the healthcare profession tell me, well, they're old, they should be depressed. I'm sorry, no. They're going to be depressed, they're old. Or they're going to have dementia, they're old. Like I said, it's not a normal part of aging. They deserve a good, high quality of life, and so do their caregivers, right? So we need to be messengers. We need to get out there and advocate for our older adults, and get them the treatment they need, get them the proper diagnosis. Absolutely. And I try to encourage people to do that, and I try to encourage more people to go into the gerontology field, because we have so few people going into the gerontology field. I teach out here, and to get a gerontology class going, even like in the social work department, we have very few people even signing up for classes. And if you go on my PowerPoint here, let's see what slide it is. Look at the demographic. Well, we've seen in previous presentations here today how the baby boomers were coming. By 2030, all baby boomers will be 65 and over. Do we have the resources to care for them? No. Do we have professionals adequately trained? Absolutely not in geriatrics. So look at that. And when you don't have specialty training to adequately diagnose or treat physicians as well, geriatricians, geriatric psychiatrists, geriatric social workers, how are we going to properly diagnose and treat, right? Who are we going to send people to? I think there was a couple people that knew what NPH were in this room. And that's, look at that. Huge, how huge a quality of life difference that could be. Just depression being treated, huge. Talk about recidivism rates, hospitals, a lot of you know what that is, right? What is recidivism in the hospital? Readmissions. right? We don't want them to be readmitted into hospitals. So if we treat the depression, the mortality rates go down and the readmission rates to hospitals go down because they're going to comply with treatment, they're going to comply with therapy, they're going to take their medications, they're going to follow up with appointments. What about socialization? Maybe they're going to get out more and do things more. They're going to have socialization. Their loneliness is going to decrease. That willingness to be part of life again, that is huge in that depression. And so that, to recover from illnesses, if you're depressed, it's very hard to recover. So you got to get that depression diagnosed and properly treated if you want the recidivism rates to go down. I don't think we do enough of that. Adequately diagnose and treat. And then the resources to actually get them into the home, get therapists in the home or in nursing homes. I can tell you we have one psychiatrist going out to my 4 counties that I have, 31 nursing homes I think I cover, or somewhere around there, 33 that I go out to. One psychiatrist that actually goes physically out to those nursing homes. One. And that person's in a county that's not Vanderbilt County, not Posey County, not Gibson, and not Warwick. They're not even in my county. He's not even in my county, any of my counties. He comes in from another county. I had, years ago when I first started, I had a psychiatrist flying in from California every several months to treat my patients here. So I do have some therapists that will go out to nursing facilities to treat some patients with psychotherapy. That's a little bit better, but still being diagnosed appropriately and getting treatment. And just the way trying to adequately diagnose, some people in the healthcare field don't go about it right. Like sometimes they're not trained, doctors, even nurses, even social workers. You don't go up to an older adult and ask, are you depressed? When you go through your scales, like your PHQ-9 scale, are you depressed? What are they going to say? No. They're not going to tell you they're depressed. They're never going to come out and tell you I'm depressed. And if you're just checking off those boxes, it's not going to happen. You're going to say, no, they're not depressed. That's a 0. I can't tell you how many times I've gone into a facility with a 0 PHQ-9 score, and I end up diagnosing that person with major depressive disorder. Absolutely. Because I don't just go by the one scale, for one thing. I'm talking to the patient, I'm talking to staff, I'm looking through chart records, talking about their history, really looking at all the nurses' notes, the therapist notes, doing a thorough assessment, not just going off of a scale. Because that's not going to tell you if they're really depressed, because they're going to tell you what you want to hear, or they're just going to say, I don't know. If someone's really depressed, you're not going to get a good assessment if you're just going off a scale, because they're going to tell you, I don't know. Ask my wife, ask my son, ask my daughter. I don't know. Right? Usually older adults will come out and tell you about somatic complaints. That's usually what's going to happen. They're going to say, I hurt all over. That's a real big one. I hurt all over, and they can't be specific about where they hurt. That's a big sign. I hurt all over. Okay. How much time do I have?
About 5 minutes.
Okay, 5 minutes. All right. Well, we're not going to have time for our quiz. I'm going to go ahead and pass the answers out so you can do this on your own. But I do want to go over real quick some of these. We've got time to do the 3 comparison real quick. So we're on the delirium. So delirium, remember, it's acute and it's sudden. Okay, it's not like your depressions that come on more gradually, usually a couple weeks or months. Or depressions can last a couple years even if they go untreated. And they can be recurrent. You can have a major depressive episode, get over it, and it can come back. We call that recurrent depression. Okay? Duration of a depression, it can last 6 weeks, and like I said, it can last longer. Deliriums usually last hours. It could be just a couple hours that you're in a delirium episode, and you can clear from that. Like when you're coming out of surgery, you can be really confused and disoriented, but then you clear real quick when those medicines get away. Or it could be, you could have it for even a couple months. If you have a UTI, some older adults are susceptible to UTIs that don't go away, that they are resistant to antibiotics and things. So you can have one that lasts quite a while. If you're hypoxic from your oxygen levels that are really low and you're not getting oxygen into your system, and like you have a really severe pneumonia and things like that, or you're really septic and you could have a delirium that's going on for a while, or if you have those medications that you're having a reaction to and that's not picked up on, those kind of things, you can have the duration can be quite a bit longer. Dementia, of course, 8 to 20 years. So you can have dementia a long time. Now, Lewy body dementia is going to be a little bit faster. Your vascular is going to be more of a stair-step kind of decline. Alzheimer's, of course, you're really going to be more the longer. Okay. Your thinking. In a depression, you're going to be really indecisive. Like I said, I don't know, ask my daughter, ask my son, those kind of things. They're going to say things like that. They're going to have a real sense of hopelessness. Also, inappropriate guilt's another one when they're depressed. That's another big one. They'll like talk about, oh, I should have done this, I should have said that, or like spouses kind of things. I should never put her in a nursing home. They'll have a lot of that. You need to really assess caregivers too. I know some other people have brought that point out. Really talk to the caregivers in the room, spouses and daughters and sons and things, because they're very stressed, and there's so many times when I spend a lot of time with the caregivers because there's some undiagnosed depression in caregivers as well, and you could just see the relief in their face when you just spend some time with them, just talking to them, and maybe offering them a support group, or saying, hey, you really sound like you have some significant depression going on here. You really need to talk to someone. Okay. Now, delirium will fluctuate. You could go into the room and they can seem all right, and then the next time you go in, they're all over the place. Also, they could be real somnolent, lethargic when you go in. They could just be kind of out of it completely. Their level of consciousness can be really down when you go in sometimes. So that's one of the signs too. And they can be really disorganized and incoherent in their speech too when you go in. And dementia, they're gradually going to lose their consciousness. Also in dementia, they're going to confabulate. They'll try to cover a lot of times. You'll ask them a question, they'll go off on something else, or they'll try to make a story up. They are going to try to hide the fact that they don't know. Okay, and that's pretty common. You'll ask them the year, and then they'll go off and say something, come up with a story or something, and they'll try to get you off that track, and they don't want to answer that. So they'll kind of confabulate and make things up, try to hide the fact that they don't know. Okay. And a lot of times in depression, they just don't want to talk to you. You're going to know that. You're going to know pretty quickly. I don't care what the year is. Just get out, or why are you asking these stupid questions? That kind of thing. Okay. They're real irritable a lot of times. Or like I said, I just don't know, I don't care. All right, mental status, they're going to be in a depression, they're going to be capable of giving you correct answers. Like I said, I don't know. And the delirium, when you're asking questions, it's going to vary depending on the time of day, and their cognition will fluctuate. And dementia, we already covered that. They'll try to confabulate, and try to cover their mistakes. Depression, usually memory is intact, but there is the pseudo-dementia. Does everybody know what a pseudo-dementia is? Anybody? What's a pseudo-dementia?
Dementia symptoms when you don't really have.
True. That's true. It's a depression that looks like dementia. It's really depression symptoms that look like you have cognitive deficits, but it's really due to depression and not due to dementia. Okay? So once you treat that depression, those symptoms are going to clear. Those cognitive deficits will clear once you treat it. So it's really a pseudo-dementia. It's not a true dementia, because if you have a true dementia, those symptoms are not going to clear, right? You don't get better from dementia, right? Once you have dementia, you have it. Those cognitive symptoms are not going to clear. If you have dementia, you have dementia. Right? It's something else. If you're properly diagnosed with dementia, that is. I should say properly diagnosed dementia will not clear. You can get started on Namenda and Aricept and things like that, but that's not going to fix it. That may slow the progression, but it's not going to fix it. It's not going to take dementia away. Okay, there's no cure right now. Hopefully, praise be, we're going to one day have it. Do the Alzheimer's walk, let's get some money raised, and hopefully one day we're going to have a cure. But right now, we do not have a cure for it. But hopefully. So your memory will be intact with depression unless you have a pseudo dementia. The depression's pretty severe enough that it's going to cause you to have your thought process is going to be off. You may start to talk and you lose your train of thought. You just really have concentration deficits. I can't think of that word, that kind of thing. A lot of times people will come to me and say, I think I have dementia. I missed my turn. I keep forgetting my keys. They stress out and they'll say things like that. And then I'll say, okay, now, when you missed your turn, did you remember you missed your turn and you're like, oh crap, I just missed my turn? Or did you go all the way home and then the next, you kept going on that road? No, I remembered right away. Well, okay, good. Or when you put, I've done this, I've opened the cupboard instead of the refrigerator to put the milk in. I'm like, oh crap, what am I doing? Oh my gosh, what am I doing? I caught myself right away. Because I'm completely stressed out. I have a bazillion and one things to do. That is normal. Okay? It's when you actually put the milk in the cupboard and then the next day you go and you get the milk out, you smell it. Of course, we talked about the sense of smell, the not being there. And then you pour it in your cereal and you go ahead and eat the cereal. And it's rotten milk. And it's curded up and you're still pouring it in there. Then you have dementia. Okay? But if you catch yourself while you're putting it in the cupboard, you're like, what the heck am I doing? You're okay. Okay? Okay. All right, we talked about sleep-wake cycle already. Usually in depression, you're going to have the early morning awakening. Like, you get up at, I always assess this. What time did you get up? Like, they'll tell me, I wake up at 4 a.m., I can't go back to sleep. That happens a lot of times, okay? And also in depression, remember, you can, it's not just sleeping too much. They can have maybe not be able to sleep, okay? And also, it's not just psychomotor retardation, where they're just wanting to be in bed all day. It could be that they're agitated and on the go constantly. They're moving and moving and moving, and they can't sit still. So it could be either or. Okay? There can be hallucinations and delusions present in all of these. And they can be frightening and paranoid in nature. So they can be present in all. Diagnoses in depression, like I told you already, and they may deny being depressed. Often there's anxiety associated with the depression as well. And oftentimes people will not really notice the depression in themselves, but others will notice that they're depressed and they'll tell them. A lot of times I'll say to the older adult, the older adult will tell me, well, other people tell me I'm depressed. They say I'm depressed. They'll say it to me. Well, they tell me I am, but I'm not. That's what they'll tell me. Okay, delirium, rapid onset, fluctuating, and it's often diagnosed as dementia, in older adults especially, often. And in dementia, usually diagnosed approximately 3 years after onset of the symptoms. It's often not diagnosed until a little bit later, okay? And then we have the care approaches. Identify symptoms of depression early if possible. You help them get into treatment and offer hope. Hope is the key, especially if they're severely depressed and suicidal. Plant the seeds of hope, okay? Delirium early recognition is important. Keep them safe and get them treated. Find the underlying medical etiology as soon as possible. In dementia, you maintain and enhance their abilities as much as you can. Get them assistance. Keep them at home as long as we can, those kind of things, because we know that's what they want. Prognosis for depression is definitely treatable. It's at 80% success rate. Delirium is treatable with early diagnosis. If it's not treated, it could lead to permanent disability and death. Dementia, it's progression. It can be slowed but not reversed, like I said. Also, depression's you can be treated with ECT, interpersonal therapy. We have all different kind of therapies now. I use CBT, which is cognitive behavioral therapy. We have all different kinds of therapies. If one don't work, go to another therapist. If you don't like the therapist you're working with, go to a different one. We have group therapy. We have there's just so many different therapies. So if you don't find one you like, go to a different one or try a different therapeutic approach. Delirium, you have to treat the underlying cause. And then dementia, we already talked about what we can do to treat the dementias. Okay, so try to get those other, I have the PowerPoint is online, basically what I already covered in here. Thank you all for coming very much.